In this video, I will discuss the pharmacological actions, clinical indications, and adverse effects of direct thrombin inhibitors. Direct thrombin inhibitors include dabigatran, argatroban, bivalirudin, decitabine and loperamide. These are anticoagulants, work by interfering with the normal function of thrombin, which is involved in the coagulation cascade or secondary hemostasis. The coagulation cascade starts via two pathways, the extrinsic and intrinsic pathways. These pathways involve a series of enzymatic reactions, which activate clotting factors involved in each pathway. The intrinsic and extrinsic pathway meet at factor 10, which is the start of the common pathway. Factor 10 is activated to form factor 10A, which in turn activates factor 2, or prothrombin to form thrombin. This is the most common point of clot regulation. Thrombin or activated factor 2 is a very important clotting factor, because it has multiple pro-coagulative functions. First, thrombin proteolytically cleaves fibrinogen or factor 1 into fibrin or factor 1A, which binds with other fibrin proteins to form a fibrin mesh that reinforces the platelet clot formed during primary hemostasis. Second, thrombin proteolytically cleaves stabilizing factor or factor 13 into factor 13A. Factor 13A combines with a calcium ion cofactor to form cross links between the fibrin chains, further reinforcing the fibrin mesh. Third, thrombin activates two cofactors. Factor 5A is used as cofactor for factor 10A in the common pathway, and factor 8A is used as cofactor for factor 9A in the intrinsic pathway. This further increases the speed of coagulation cascade. Finally, thrombin binds to receptors on platelets, causing them to get activated. Activated platelets change their shape to form tentacle-like arms that allow them to stick to other platelets. When direct thrombin inhibitors are administered, they can bind directly and reversibly to thrombin in the circulation, as well as those already attached to a forming clot, inhibiting any further conversion of fibrinogen to fibrin. Without thrombin, factors 5, 8 and 13 are also not activated, thus bringing the coagulation cascade to a halt. By reducing the thrombin-mediated activation of platelets, direct thrombin inhibitors also have an antiplatelet effect. Argatroban, bivalirudin and loperamide are given intravenously, decitabine is given subcutaneously, and dabigatran is given per oral. Loperamide and decitabine are recombinant derivatives of the hirudin, which is the most potent natural inhibitor of thrombin and found in the saliva of leeches. Bivalirudin is synthetic bivalent analog of hirudin, with a thrombin inhibition activity nearly 800 times weaker than that of hirudin. Although direct thrombin inhibitors are not as frequently used as heparin, these drugs can be used in patients with a history of deep vein thrombosis to prevent pulmonary embolism, or atrial fibrillation to prevent strokes. We can use these drugs in combination with antiplatelet agents, like aspirin and clopidogrel, to prevent clot formation in patients undergoing coronary artery surgery. There is one unique indication for direct thrombin inhibitors. It's heparin-induced thrombocytopenia, which means platelet count drops occurs during or after heparin therapy. This is like autoimmune reaction, where the antibodies attack platelets in the presence of heparin. It is a serious complication, and if the patient is diagnosed HIT, we stop heparin and switch to direct thrombin inhibitors, such as dabigatran, argatroban or bivalirudin. Now let me discuss each drug in more detail. Dabigatran can be taken orally. It is also referred to as a DOAC, or direct-acting oral anticoagulant. It is important to note that dabigatran is very sensitive to moisture, so the capsule must be kept in the original container or package, away from the moisture, and never in a pill box or pill organizer. The whole capsule must be taken orally and cannot be placed down an enteral feeding tube. The capsule contents cannot be opened, crushed, or altered in any way, as this increases the risk of side effects. We can use dabigatran 150 mg capsules twice a day in atrial fibrillation, deep vein thrombosis, or pulmonary embolism. If we want to prevent DVT, meaning these patients don't have a blood clot, but they are at risk after a major surgery, we can give dabigatran at a lower dose, 110 mg within first 4 hours after surgery, and then 220 mg once a day for up to 1 month. The duration depends on the type of surgery. We do not have to do blood tests routinely. Instead, we have to be mindful of creatinine clearance to know how well the patient's kidneys are working, as this drug is cleared by the kidneys. If the creatinine clearance is more than 50 milliliters per minute, we need no dosage adjustment. If the creatinine clearance is less than 50 milliliters per minute, we may need to use at a lower dose. Dosing of argatroban is different. It is weight-based dosing. It is used in prevention and treatment of thrombosis caused by HIT, as well as in patients with or at risk for HIT who are undergoing percutaneous coronary intervention. Argatroban is given 2 micrograms per kilogram per minute continuous infusion. Then we adjust the rate of infusion by monitoring APTT. This drug is cleared through the liver, and not the kidney, and thus it can be used in patients with kidney disease with no adjustment of starting dose. Bivalirudin has similar indications, efficacy and safety as argatroban. However, bivalirudin is partially excreted by the kidneys, so we need to decrease dosage in patients with renal impairment. In terms of side effects, direct thrombin inhibitors are associated with gastrointestinal symptoms like dyspepsia and gastritis. The most dangerous thing is the risk of increased bleeding when taken in excess. This could lead to uncontrollable internal bleeding from simple falls or trauma. A reversal agent called idarucizumab, an antibody which binds to and inactivates dabigatran, can be administered to patients who experience uncontrolled bleeding. Idarucizumab does not work for the other direct thrombin inhibitors. There is no reversal agent. Prothrombin complex concentrate, also known as PCC, which contains the coagulation factors 2, 7, 9 and 10, along with proteins C and S, or antifibrinolytic agents like as tranexamic acid, can be used. Other common toxicities include hypersensitivity reactions, especially with loperidone and bivalirudin. Direct thrombin inhibitors should not be stopped suddenly as it leads to increased thrombosis and risk of strokes. If you learned something new from this video, make sure to subscribe to our YouTube channel. If there is any suggestion, please let me know by leaving a comment below right now. Thank you for watching this video. Stay safe and healthy.